the only way is to move work and thinking further upstream. And the only way to do that is to be much more smart about how we use data. And that is absolutely critical, that we help people to understand that in order to be more preventative about care, more predictive, much like other things in their life. Is it going to rain later this afternoon? How do we understand that? We've got to try and help people to go on that journey.
So, welcome everybody to all of our guests, both online. I think we have about 180 people joining us online. So very much welcome to our online guests and also to our studio audience. And really, thank you for making it here on time. This is the last of our digitally transforming healthcare broadcasts of 2022 in partnership with Chamber UK. So by means of an introduction, I'm Angela McFarlane. I'm Vice President here at IQVIA for UK and Northern Europe Strategic Planning. We've had some amazing events this year, starting off in a very cold Cambridge in February with Science Minister George Freeman. Then we went up to Liverpool in June with Andy Burnham. I think the attendance there was somewhat impacted by the fact that it was a beautiful barbecue night. And then the Edinburgh with Cabinet Secretary for Health and Care, Humza Yousaf. So we're very pleased to welcome you all to our humble abode here in Paddington, London, for tonight's event. I know that most of you will already know, but as a trusted partner of the UK government, IQVIA is working to turn the UK's potential as a global life sciences superpower into a reality. It's a highly competitive global environment, particularly for clinical trials. And IQVIA works really hard to make sure that when we win a sponsored trial, the UK is at the top of the list of where we're going to bring that trial to. As a global human data sciences company and the leading global provider of advanced analytics, technology solutions and clinical research to the NHS and life sciences industry, IQVIA is the third largest life sciences employer in the UK, and we employ over 6,000 people, the length and breadth of the country. To introduce our panel this afternoon, this esteemed panel, which I think is reflected in the audience here and also those online. We have Dr. Tim Ferris, National Director of Transformation at NHS England, Dr. Bob Klaber, Consultant General Paediatrician and Director of Strategy, Research and Innovation at Imperial College Healthcare NHS Trust, and very much our neighbour in St Mary's Hospital just over there. Professor Ian Abbs, Chief Executive Officer at Guy's and St Thomas's NHS Foundation Trust, and Ros Campion, who's the Director of the Office for Life Sciences. So may I invite the audience to welcome them in the traditional way. And just to note on the topic tonight, I know that most of you will be familiar with our long-standing title, Innovating Healthcare, but we decided to slightly alter tonight's title to reflect Tim's participation. But we have selected questions that cover the breadth of innovation across healthcare and life science, including partnerships with private sector. You can join the discussion online via Twitter at Chamber Voice, hashtag Innovating Healthcare. And we're going to have poll questions throughout the event. So please do take part in those poll questions. Before bringing in the audience, and if you have a question, we're going to have a roaming mic, which is going to be womaned by Shivana. As chair, I'd like to open the discussion with a few questions. So Tim, I'm going to move to you first. Everyone across the system of healthcare and life science sees the potential of England to become a world-leading country with our unique health data. Are we going to succeed? And what do we think are the barriers that are going to get in our way?
There is only one answer to that question, because if you don't answer that question in the affirmative, then you will fail. So optimism, whatever the optimism bias is, but you have to assume as you attack this problem with such a terrific ecosystem that you are going to succeed. So there is no question. So then the question is, and that's the second half of your question, is what are the challenges? So actually what I found really gratifying in this position that I'm in, this honored position that I'm in, is that there isn't a lot of disagreement about what the challenges are. There are disagreements about how to approach those challenges, but not what the challenges are. And And I would say one really important challenge has been in the past what to go after, because it's a target-rich environment. You could go after so many things, and that's why I want to point to the life sciences vision as one of the enablers, because the life sciences vision provides our North Star for what to go after. It really does crystallize against the really big challenges that we face in health and the delivery of healthcare. I'm going to go I know you asked for pithy responses. I'll go one step further and just say, so for my perspective, the challenges facing the delivery of healthcare come down to actually one problem. And that one problem is the demographic changes of most Western countries and the aging of the population. Our current bed capacity, GP capacity, our specialist capacity, our diagnostics capacity, every single one of the challenges that you read about in the paper comes down to the fact that the people planning 20 years ago looked forward to a technology benefit that did not materialize in nearly the magnitude that they planned for. And that is, we wouldn't need all those beds because we were moving things to outpatient. We wouldn't need all that diagnostic capacity because we were going to modernize and adopt new technologies. So there was an optimism bias 10, 20 years ago that leads us to our current position, which is actually we are seriously challenged, and I'm not saying anything that anyone doesn't know. The life sciences provision provides us provides us with that North Star. The challenges between here and there are selecting the particular paths that will reach solutions most expeditiously. That's where the debate comes in, and that's why I'm so looking forward to this conversation as part of one of many conversations where we actually talk about what are the best, most expeditious paths forward. And then I'll just close by saying most change theorists talk about the importance of a burning platform. I think we have a burning platform.
We have a burning platform. So you talked there about failure not an option, about optimism bias. So it's the fault of the people 20 years ago who aren't here anymore to defend themselves. But I know that Bob's going to pick up on that point about that, about being able to address the upstream, which is what was failed to do last time. So I'd like now very much to go to Ros to pick up. So Ros, I think you've been set up beautifully there. With the enthusiasm in the life sciences vision, how can we use the life science vision as a North Star or a roadmap?
So I think there are a couple of things. For me, the life sciences vision, there are two planks. One plank is about delivering system change. So many of you will have seen that this time last week, it felt like a very long week, but this time last week we announced 4 more of our healthcare missions, which were about trying to take a big leap forward in terms of seeing how we as a country can tackle some really big population health issues. So you've got your system change. We've also are looking at making really big investments, for example, in the medtech pathway to help try and speed innovation into the system. But then for me, the second big plank, which is just as important, but perhaps sometimes gets a bit less attention, is, well, what do we do right now? And thinking of that burning platform, how do we work as we did during COVID in partnership with all the different bits of the system, whether that be industry, government, the NHS, to try and say, well, this particular problem, how can we collectively solve it? And it's really striking for me. Tim and I were talking before the panel about the succession of ministers that I have seen over the course of the last few months. And there has been a surprising amount of commonality between what they've been saying. I mean, all of them have said economic growth, yes. All of them have said life sciences, yes. All of them have said learning from COVID, yes. All of them have said, let's try and make sure that we don't have another pandemic, or a more, polite version of that. This particular set of politicians that we have, and clearly, there is going to be some longevity, have got a real focus on how can we go back to solving a few problems right now. The problems of winter, what can industry do to help? What can the NHS, how can the NHS use innovation differently to solve some of the problems right now? So over the course of the last few weeks with our new ministerial team, I have more than the whole time that I've been doing the job been having conversations about, well, is there, given the pressure that GPs are facing, how can we take some of that demand off them through different solutions? So I think that there is the burning platform that Tim talked about is one that's particularly felt by the ministerial team more than some of the previous ones have done. And so that gives me quite a lot of optimism, although I note optimism bias and the risk thereof, but that we have both the opportunity for the system change that the life sciences vision, a 10-year strategy set out, some of the big planks that we put in place, but also the opportunity for you can't really say leaping into a burning platform. That sounds deeply dangerous and really unpleasant, but whatever the less unpleasant version of that is.
So having this kind of one mission approach like we had during COVID around that burning platform, yeah? Ian, may I come to you? And I'm going to link two questions together for you. Ian, as many of you will know, is an absolute passionate advocate on innovation adoption. So Ian, I'd like you to give some insights from your perspective about the value proposition for innovation adoption. And then the second part of that question is, how do you actually increase the rate of adoption and spread of innovation?
Well, thanks very much, and fantastic to be here this evening. A couple of thoughts, really interested in this audience's response. The first is, I think most of us would feel there's no shortage of innovation. We are a highly creative country, highly creative community. I think the conundrum is those innovations exist, but they're so far not penetrating the issues that we face. And put simply, as I think Tim's already introduced, global healthcare is simply not sustainable in terms of high quality access and outcomes in an economic model if we don't address this now. A few thoughts. One of the issues which I've tussled with is, in many ways, at the moment, the model of innovation adoption appears very much to be an additionality model. So we tend to put another layer on the cake. So we build this layer cake of complexity and cost, and we haven't yet thought, I think, purposefully about how can we change that model. So could we develop models which are substitution models, which for each innovation adopted, we strip out the old. Now that is a very, very easy thing to say clearly, but it's difficult to do. But I think most of us in this room could think about where an innovation, if adopted, would make a difference, and where we could substitute by withdrawal of what we do at the moment. Because I think that's the only, a substitution model is probably the only long-run viable economic opportunity. Why do we find that difficult? I think it's a combination of culture issues. I'm very interested to know what colleagues, particularly Bob and others, feel about the cultural issues to block us to change. I don't think we have upstream enough conversations with the payer system and the planning system on care, and that we were somewhat surprised by some of the innovations that have come forward, that we haven't been able to rapidly adopt them. And then to be explicit in their adoption about what we're going to stop doing. And health systems around the globe, us included, are very bad at saying what we're going to stop doing. But those would be three things I would advocate.
And have you got any examples, Ian, of that? What do we stop doing?
Well,
in order to accommodate innovation.
I'll give you an example. So I was with our cancer data team today. And the MDT model was brought in for very good reasons, to go from singular to group decisions about patient care, particularly in clinical pathway optimization around treatment, including chemotherapy, for example. However, that is a very, very workforce-heavy process with 30 to 40 people, usually in a poorly data-supportive environment, taking analog decisions about steps on patient pathways. and some of those MDTs lasting 4 hours and multiplied across all the tumor groups. That can't be the best way to, an MDT model was set up for an absolutely brilliant purpose. But were we able to bring innovative AI-driven data pathway management into the care of patients, then we could actually look at substitution models.
That's quite ambitious, because the MDT is one of those kind of holy grail things, isn't it?
But I think it comes
and that
back
comes back to the culture.
the culture issue.
Yeah.
Can I do very quickly just say the classic example of addition is in radiology. So most surgeons, with each additional imaging modality, just add that additional imaging modality. They don't substitute, even though each one is better than the last. So you're getting the X-ray, the CT, and the MRI, rather than just the best particular. But it's really wasteful. But from a clinician's perspective, when is it true that less information is better? That's the justification of it. But it's not economically viable.
And if I'm allowed one last example, straight to MR on headache pathways has an aggregate saving of about £375 per patient pathway in the literature.
Thank you. Bob, building out on those, and as obviously a practicing clinician as well as a leader in the system, how do we best ensure that our local communities are front and centre of a digitally enabled healthcare system? And maybe this is an opportunity to reference One London.
Yeah, thanks very much. And sort of joining in and picking up on the conversation before, I mean, the thing for me that cuts through waste in the most wonderful way, I learned from a man in his late 80s who was our first strategic lay partner, an amazing man, the late Michael Morton, who had a very simple bit of advice, and he said, value the patient's time. If you want to think about ex-innovation and taking stuff out, utilize that as your real true north, and you get some really, really interesting answers. We deeply over-medicalize things. We create much more complexity than we need to. And I think as I was listening to that conversation, that would be the way I think, cut through that, which plays really nicely in a way to your question about data and about trust. And I've been long sort of interested in conversations with patients around how do we all know in our hearts, and everyone in this room, that data, innovation, transformation, how we utilize big data, how we bring AI in to improve care is going to be critical. But we absolutely have a duty and a need to really take people in on that journey. And for good reasons, people have suspicion and worry around it. And there's plenty of case studies that we all know from outside healthcare and indeed inside where that hasn't always been right. So I think work like the One London deliberative democracy work that is worth looking up if you don't know it, was really, really important signal to us about how we need to go about working with our citizens, with our local communities, to really truly understand what are the things that really matter to people. When you look at the detail of it, people were very, very bold and clear that we have to utilize depersonalized data to plan and improve care. There is a moral obligation that we do that, but some really important safeguards in and around it. I think we have to help people to really understand, to me, the moving upstream, the moving from the repair shop that we're all, the teams working at Ian's organisation, my organisation, working extraordinarily hard to try and tackle backlogs, huge numbers of people coming into urgent and emergency care, and indeed across the system. The only way is to move work and thinking further upstream, and the only way to do that is to be much more smart about how we use data. And that is absolutely critical, that we help people to understand that in order to be more preventative about care, more predictive, much like other things in their life. Is it going to rain later this afternoon? How do we understand that? We've got to try and help people to go on that journey. And I think that's about really good conversations. It's about great listening, but doing that on a continuous basis.
And can I ask you, what about the trust that was built up by the public in the use of their health data during COVID? Has that now all kind of gone back to business as usual, and there's still a lot more work to be done there?
Well, I want to just challenge the trust bit in some ways, because I'm sure some trust was built up, but also people got very worried about the role of central government. And I learned an extraordinary lesson around race and racism and structural racism that is a huge issue for us to tackle in this society. So we were doing work around vaccine equity, and 6-8 weeks after the extraordinary vaccines had landed, and we were looking at data, and it was a really good example of use of data to understand what was going on. And as we all know, the communities who were most likely to suffer the most from COVID were the least likely to want to come forward around having a vaccine. So what was going on there? And we ran a series of 10 vaccine equity huddles to try and ask that question. Open public meetings held on a Tuesday evening online, and all sorts of people came and joined in. Third meeting, this extraordinary woman called Adiola said this phrase that I'll remember for the rest of my life: why now? Why are you and your organisation and the NHS, why are you interested in me and my family now? You've not been interested in us previously. And I think that piece about trust, it got me thinking very, very hard. The only good bit that I came out of is I didn't try and answer the question, because there isn't an answer. The answer is that we have to act in a very different way. So I think building trust around wider issues around health and care and research, and if we're to succeed with the sorts of missions that Tim and Ros were talking about, we have to have a very different compact with the public, and it involves thinking about power and ceding power in a very different way. It requires a very different approach to what we've done historically.
So can I just build that out? And this is really one sort of yes for you, Bob, but I'd quite be interested in Ian's perspective. The kind of tribalism that exists within the NHS. So how can we, for example, in London, ensure that multiple systems across the geography can work together? I talked earlier on about, a very highly competitive global clinical trials research ecosystem. Everybody wants to grab that study for themselves, but how on some of these big population challenges can whole systems work together? So Bob,
I'll go really quick. It's back to culture. And Tim introduced this piece about how bold are we prepared to be as soon as we start getting over tucked into our small, medium size. We might think they're very big in our organizations, tribalism. We're not going to achieve the sorts of things we have. I think it's been one of the biggest failures of leadership. We're all in it, but lots of people in this room as well, and it requires a real pivot and a real place to work differently. So it depends. How big's your vision? How much do you want around it? 9 million people live in London, and indeed, when you look at the country, you're right up in the many tens of millions. And the opportunity there we have, as Tim introduced, is different to anywhere in the world. So where's the set of behaviours, the set of leadership behaviours that can match that? History isn't on our side, so it requires something different.
I think if I try and answer that, one of the things I've learned over the last couple of years is that provided we can articulate purpose, then we can bring coalitions together. And I've been really pleased with Mark Warport to be chairing the London data programme. And we have a coalition of all of London's 5 ICSs, of our higher education institutes, of our larger healthcare organisations. And we have put a submission in for the subnational TRE that covers London. It's 10 million people. And that opportunity, I think everyone recognises that there is opportunity of scale. And if we can bring actionable insights from those data, and then with an effector arm, improve the healthcare of London, but actually from that as well, derive actionable research insights that again link back into the improvement of people's health. And as Bob said, I think most members of the public have a very clear view that purposeful use that has that type of virtuous cycle is absolutely what they support. But it's our job to keep that coalition together.
Thank you. Thank you. Okay, we're going to move on to a poll question now. So members of the audience, I need you to show your hands. Members of our online community, you can vote online as you would normally do. So the first question, and we're going to repeat this at the end, is how confident are you that the UK will achieve its ambition to become a world leader in health innovation? Are you Very confident. Audience, anyone very confident? Thank you. Confident. Somewhat confident. Not confident. And not confident at all. So perhaps the panel will help me, but I'm thinking that we were getting a somewhat confident and confident consensus, certainly from the studio audience. Yeah? Okay, we're going to repeat that at the end. So we're now going to go into the data question side of tonight's event. And we're going to take some questions from the audience. So Shivani's there with her roving mic. So our first question is going to come from Shane Tickle. Shane is CEO, founder of Oral Health Technologies. So the mic's yours. He's just down here. Thank you.
Just before I ask the question, if I may, I just want to qualify it. I've also been in the electronic patient records industry for nearly 25 years, the health data industry for 3 years, and I'm vice chair of Tech UK, helping Sonia Patel chair the NHS and Suppliers Forum on the frontline digitization piece. And my question is, can data convergence be more helpful than trying to crack interoperability in the race to the end? And now I say the end, thinking that we'll all get data to talk to each other at some point. But I've been working on interoperability for 25 years.
So we'll direct that question to Tim, and then I think to Ian.
Well, thank you, and my condolences for your participation in those. It's tough work. I think it's an and. It is not one or the other. It's an and so let me explain that just a little bit, which is converging on fewer data systems will enable easier interoperability. I believe, after looking at this for a couple of years, and I could be wrong, that unlike some other smaller countries, converging for the whole country would be sort of politically untenable, and actually from a practical basis would be extraordinarily difficult, as amazing as that would be from a data access, data model perspective. Incrementalism, I'm what I would call a raging incrementalist. And that is incremental steps, but keep pushing for that next incremental step. Right now, we are looking to converge our systems around ICSs that will simplify the data environment. We also need to simultaneously move forward with interoperability. I do want to also say that I'm speaking about direct care, and it's very important because often when people are having arguments about data and data availability, it's because what they're thinking in their head is a different use case type. And I have 4 distinct use case types that I carry around with me, and I want to make sure that every time I talk about this or have a challenge from someone else, are we thinking about the same use case type? I was just discussing direct care data architecture. There is a different data architecture for population health that involves both identified data and de-identified data. There is a different data architecture for planning that is exclusively de-identified data. And there is a different data architecture in information governance around research data. All of those things, you have to think mentally, which one of these am I talking about? And let's be specific. Because often when people are challenged to understand or challenged to accept the premises of what you're talking about, it's because they have a different mental model for what it is you're doing with the data.
Okay, really comprehensive answer. Ian, can you build on that?
Well, I'll try and give 2 reasons to be optimistic. First, the issues of bringing data together in the same architecture and the same layer for London. I would never have thought, even as little as sort of 5 years ago maybe, that we would have the sort of one London data layer and the work that's gone on across London. And we're starting to see some actionable insights, whether that's in Southeast London or Northwest London on hypertension, in Northeast London and Southwest on immunization data. And actually we are starting to see that now. And that's with a multiplicity of different systems, but there is now communication. So I'd take that as an optimistic outcome. The other thing I'm optimistic about is I grew up in a world, shows my lack of technical knowledge, that said, well, you've got to put, if you're going to do anything interesting with the data, you're going to have to put it all in one enormous lake and then interrogate it. So we'll have to have lots of IG agreements where we're pushing data from different systems into some enormous lake. But the federated learning models that have come out of some, so we have an AI center at King's, and that's got 11, I think, NHS organizations with variant underlying systems. So with Bob, it's Cerner. With UCH, it's Epic. We have one about 21 years old. It's an old iSoft system. But the federated learning that takes the training algorithm to the data and brings the algorithm back, but not the data, is actually something that's really, I think, revolutionary. And if we can get that type of federated approach really working in this country, then I think we've got a huge opportunity.
Great, thank you. I hope, Shane, that that's something you could maybe take back, both answers to Tech UK. If you can answer it quickly, I'll indulge you, but super quick, because I'm getting
So Varroa, my company, is the one that's supplying One London's 3 ICSs with a discovery data platform, where we're normalizing data across different acutes, primary care, community, out of hours. It's about 7 million citizens. We're getting about 1.5 billion calls on that data. It's used for direct care, de-identified for population health, and it's used for research. So it's collect it once, same architecture, use it many times.
Thank you, Shane. Thanks for being so quick. Is Dr. Martin McShane here today?
Hi, thanks very much. Having been around for quite a long time, I first started, the first thing that was drilled into me is first do no harm. As my career's progressed, I've seen more and more people harmed by our inability to link data. So what's the ethical justification for not linking data to improve quality and efficiency in health and care delivery? And if there isn't an ethical justification, shouldn't we all be reporting ourselves to the GMC?
Great question, Martin. Who would you like to direct that to, Tim or Bob? I'm going to say Tim or Bob.
Yeah, I'll direct it to Tim.
What a wonderful articulation you just made. It's what I call the counterfactual to change management. And that is, when people are resistant to change, they are assuming that status quo is better than the change. And they point out all the problems that could occur with the change. But what you just highlighted is there's a lot of problems now. And the obviousness, is that a word, obviousness? Okay, I'll take it. It is now.
We gave you our language 250 years ago, and look what you've done with it.
Is of how you can use data to improve vaccine coverage in a particularly underserved neighborhood, or like, I'm not exaggerating, 1 million other ways to use it. It is, that's the counterfactual that we have to face up to. But you did ask what the problem was, and the problem is not its perception of privacy. It's not privacy per se, it's perception of privacy. That is an absolutely legitimate concern. It's a concern I have, it's a concern my kids have, my family, everyone has a legitimate concern. And so it is on us, it's on me, to provide sufficient assurance and reassurance that we hear the concern and we are doing a really good job of addressing that concern. Because beyond privacy, there is no other justification from my point of view.
I'd like now to go to some of our online questions. We've got some great questions. So I'd like to start with a question from Olivia Houlihan, who's a transformation lead midwife at NHS England. How can the transformation agenda link in more effectively with other compliance and improvement requirements to reduce the reporting burden on trusts? Who'd like to take that question?
So it's a really great question. And I guess my brain goes in 2 or 3 ways. So one of the, I guess as a sort of paid up, learned up improver, you need data and information and insights to understand what you want to improve. You need to understand baselines. And as you test and try stuff, you need to know whether it's making a difference or not. And I think one of the big issues we've got is we don't have enough of that out in the hands of teams who are trying to make a difference. Whether they're looking after a pathway of care, whether they're thinking about a busy ED department, or whether they're sat in a primary care network thinking about how they improve population health. Back on culture, the reporting culture we have in this country is a massive issue and burden on that. Most of our analysts' time in provider trusts is spent essentially feeding that machinery. And I think, interesting to bring Ros in a bit on the politics and Tim in on the politics of it, the sort of political thirst around that stuff. So we have a limited resource focused on how do you turn data into analytics and insights and putting that genuinely in the hands of people with great sort of visualization. That is a massive gap for us at the moment. Most clinical people, if you ask me as a general paediatrician here, how do I know I'm any good? The answer will come in Christmas cards, not in data and not in analytics. And that's something that's really solvable. So we're incredibly data rich. Most of it heads on up in the reporting assurance space, and it's not out there for improvement.
I want to move to another online question. So we've got Jason Bradley, who's a strategic advisor at Warrington and Halton teaching hospitals. And I think it's kind of linked a little bit to the first one. So pithy answers. How do we embed digital into the transformation agenda of all organisations? Who'd like to take that first?
Shall I have a go? So I think it comes back to the value proposition, really. I think there's a strong, and Bob's articulated it well, a very strong argument for purposeful data-driven care may be better care, but we have to measure it. And that if one looks at continuous improvement cycles, it's possible to reduce the cost component of value equation. And if that is accepted, then that is a strong argument for adoption. I think the second thing I would say is getting it on the agenda. And one of the things I was very struck by at a meeting, I don't know how many trusts in this country have a chief digital officer with a role in transformation with the CMO and the CNO on the board of organizations. And I think one challenge for us in this country is to accelerate those roles on boards.
Maybe we can do some research on that. I think that's an incredibly helpful suggestion. And I think you're right. Certainly from our perspective, when we want to put in real world studies to any UK organisation, we tend to stumble at the first hurdle with the information governance people. And it'll take them 9 months to decide whether they are going to allow us to do what NHS Digital have already said we could do. And then by that point, the study's been finished and closed in the Scandic. So I think that's a really cracking suggestion and very pragmatic.
Can
Ros,
I just come
please
in?
do.
Not to disagree exactly, but just to sort of note, and also we should be seeing this as a transition phase, right? So Tim talked earlier about decisions were made 20 years ago. I mean, so I'm hoping that 20 years from now, we don't necessarily need to have chief digital officers on the boards of organisations, because it is so ingrained in the way that people are working that you would having a person who is responsible for that would be a bit weird, because you'd be I absolutely agree that it's necessary as a way to get to the end result that we need to get to, but I don't think it is the long-term solution.
Okay.
Well, if I can, I don't disagree with you. However,
oh, I don't disagree. That's a very well. I didn't quite disagree with you either.
Well, at least neither of you have said with respect, which means absolutely no respect at all.
If I was going to link that point with Bob's earlier, though, we are not yet in this country addressing some of the fundamentals like from the STEM subjects, how many young people do we have going into analyst jobs that are not going into the city to do economic analysis? Most of the clinical teams, Intermountain may not be the best example in the world, but each of the clinical teams in Intermountain has an embedded analyst. And that type of approach and digital literacy in the workforce, I don't know, I'm pretty sure, Bob, that digital analytics is not part of the undergraduate medical curriculum in most UK universities.
So on that happy note, we will call we're going to move on now to our poll 2, please. So, member audience, hands up. In what ways can we enhance the adoption of digital transformation? So if you're in the studio, please put up your hand if you've got some ideas. And for online, please put your comments into the chat box. Is that the right question? Yeah? Anybody got any ideas about how we can enhance the adoption of digital transformation? So any brainwaves on that? Gentleman over there.
Hi, thank you very much. Steve Leighton, I'm a GP in St Albans with a public health background. It was listening to the earlier conversation about multidisciplinary teams, which reminded me of a story when my dad was end of life in Sheffield about 6 years ago. And as well as being a strong Yorkshireman, asking him if he's all right, he said, never been better, son. He also said that the multidisciplinary team were going to meet about him, discuss his case that afternoon, and they'll ring him later with their decision. So I think one of the ways, and I'm just thinking about the utility of a multidisciplinary team, the absence of the patient, the fact, as Bob said, that patients often choose less expensive interventions when they're involved in decisions. I think we can enhance the utilization of technology and the strategic direction of technology by bringing patients and patient leaders much more into these discussions. I think a lot of technology that I've seen is clinician and service facing. I don't see a wealth of technologies that are patient facing and public facing, and I think that's what we need to do.
So was it Steve?
Steve, yeah.
Yeah, Steve, you had a lot of violent nodding there from the panel. Anybody want to build out from that in the audience? Shaima.
Hi, I'm Shaima Ali and I work at IQVIA. Just to say, Steve, you're not just a GP. We did some work together 15 years ago to introduce shared decision-making and informed medical decision-making into the NHS to tackle unwarranted and warranted in some cases variation. So I think there's still a lot to do in that space.
Very quick, very pithy. So I think the biggest missing part for me, I'm Will Pope, by the way, I'm chair of Yorkshire and Humber Academic Health Science Network. I think the biggest thing that I see most commonly missing is that we are looking at data and the numbers and not converting data and the numbers into information. So we've got to turn the data into useful information, and that's the biggest challenge.
And gentleman in the back there, and then that's probably going to be my last question for this section, if I may. Yeah, I'll come back for this section.
Sure. Very, very quick, pithy comment. I'm Murray. I'm also just a GP. I think the challenge for us is that we're very good at funding the technology, but we don't think about funding the transformation that's needed to embed the technology. And we hand it over to procurement, who drive the price down, and then actually expect teams just to get on with it and embed it. And then you get what Ian described, which is that kind of layering on. So in general practice, we have telephone triage, and now we also have online triage, whereas we should have online triage instead of telephone triage. So, an example.
Great, thank you. Thank you for being both pithy and positive and pragmatic. We're now going to move into the innovation section of the discussion. So again, I'm going to take a question from our online audience. Tayo Owaduni, she's Programme Manager for NHS England. How can the UK continue to punch above its height and weight in medical and life sciences innovation and adoption in the middle of sector cuts and recessionary times? And there's only one person I want to go to for this question, and that is Ros Campion.
What a glorious lead-in. When we did the poll earlier on how confident are you that we will end up taking advantage of life sciences and innovation, I looked carefully to see when my colleague from OLS put his hand up, and I was cheered to see that he put it up at the confident, although not very confident. I do, however, very much want to hear from our colleague in green, who was so unconfident that he put his 2 hands up, which felt a very grim version of unconfident. But to come to your question, I mean, how do we punch above our weight? I mean, I think it comes very much to all of the things that we have talked about, right? So it comes down to the question of, do we manage to find a way, do we capitalise on the learning that we had during COVID about working in partnership between government, NHS and industry? We have made, as a country, quite a lot of big bets, financial bets, that should help us keep on punching above our weight. So in the genomic space, for example, in the health data space, where I'm very glad that Tim is confident that we're going to succeed. We have made significant, like huge bets in terms of R&D investment. That's made me sound either more powerful or less powerful, depending on. And I don't know which one I'd rather. Do I have the would I rather have the power to cut the tax credits, or would I rather? Anyway, moving on. So we have made a lot of big bets, and recognising the tax credit point, but we have nonetheless put a huge amount of government money into health R&D in the sort of several billion type camp. So all of these big bets are about trying to make sure that we are enabling ourselves to do that punching. But then it comes down to, are we enabling the system to capitalise on it? And that, I think, is the really tricky bit. And it's sort of what we've talked about, you know, a colleague earlier was talking about, are we investing enough in transformation and how we're enabling us to take up that? And I would say probably not. But so for me, it is a question of, we've made big bets, great. We've got quite a lot of the system trying to point in the right direction, but there is quite a big space that we have not yet managed to push through. That will be the final mile that will get us to punching above our weight. And that will come down to, you know, have we got the right connection between local innovators and the NHS? Have we got a real sense from across ICSs about what's important and what's not important? Have we managed to avoid having sort of yet more layers of questions being asked by political teams, so more and more data being asked for? So one of the things I'm really conscious of is I think that there's a large number of people who are still answering the question that was asked by 3 governments ago. And so, like, how are we trying to find ways of cutting those bits out, so that we are really clear about, well, if we've made a set of investments, if we've got the system more or less pointing in the right direction, and then we've got a few things to try and get into the right place, have we focused enough on getting those things into the right place? And if not, how can we push them over the edge?
Okay, so I'd like to take the next question from Raoul Chowdhury, who's Medical Productivity Director and Consultant at NHS England.
Thank you very much. I work at the front end of accident and emergency, and what I see is disadvantaged populations are one of the biggest users of NHS services and are absolutely reliant on it. So how can data innovation make it to that vulnerable, disadvantaged group of population?
And Raoul, when you talk about disadvantaged population in its broadest sense.
Yes, indeed. So families whose English might not be first language, to our elderly population who really struggle to even register their NHS number at the outpatient kiosk, or if you work at a hospital like mine, which has 7 miles of corridors, try finding your clinic room. Even basic wayfinding is not that easy.
Yeah. Thank you. Thank you, Raoul. Bob?
I think the question you ask is research and innovation's biggest challenge in the decade ahead. And certainly I'm responsible for the research at Imperial College Healthcare. That is the very, very clear single message that I give to the teams who we'll work with. It is the biggest challenge, and everything else can follow. We've commissioned and run healthcare services largely based on what we did last year, plus or minus 3%, depending on what's going on, rather than really focusing on need. So how do you start everything with need? How do you really deeply understand issues around equity and then start gearing them up? What's interesting as well is we've talked about really big data, but we're sat here in Paddington, and Angela and I involved in really interesting work across university, NHS and industry. And it also has a hyperlocal focus to it. So the work that we're doing work together around data, but the things that have probably got people the most focused and excited, one is about equity of access into research opportunities. And the second bit is about social purpose. So some really interesting work that we're trying to do together around digital inclusion, around things like developing a local community space where we can engage with people. So I think we've been asleep around this stuff. Don Berwick talked 21 years ago about equity as a domain of quality. Michael Marmot 20 plus years ago. We've largely ignored that for all sorts of reasons that are not really defensible. The floodlight's now clearly on it, and we absolutely have to have a very, very clear focus around that going forward. And back on data, we need to be looking and tracking about how we're getting on.
And Tim, can I just ask you to bring in a kind of NHS England inequalities voice?
Yeah. So building on what Bob just said, which I couldn't agree more with, and to speak specifically about the data. So I don't know if it's publicly available yet, but actually there is actually a disparities dashboard for every ICS in the country that is being distributed to the CEOs and board chairs of every ICS in this country. I hope I'm allowed to say that. Whether it's been public, whether it's public yet, or it will shortly be public, that's the kind of thing where the center has a real role to play in aggregating the data and then feeding it back once aggregated on comparative performance and saying, how are you doing, right? We haven't done that before. We are doing it now. It's not sufficient, but it's necessary. And the next thing, and this is one of the more gratifying things for me as I go around the country, just to reinforce what Bob was saying, I find no greater motivating force among the people who work in the NHS as addressing that challenge. So if you have the data and you have the will, and there is clearly the will, I think we're going to make real strides in the future against this challenge.
Thank you. Thank you. Gentleman in the green, would you like to, do you have a question? I mean, I know you made a comment, but.
Thank you. My name is Benedict. I run a company called Sanem. We build early warning systems for health deterioration. And there is no better time to build one of these things. But this is my 5th company in the UK. I've built tech companies, I've built digital health companies, I've employed hundreds of people, built lots of revenues for the government, had a couple of exits, so it's great. But trying to do something in healthcare. I'm 2.5 years in. I'm still waiting for ethics approval to get database access. I'm still waiting for more access for clinical trials. And I'm waiting to try to find someone in the NHS I can talk to. There's wonderful, wonderful people, but we just go through meeting after meeting after meeting after meeting. And slowly I'm going to grind down. So the question, if I can be trusted, or if there is a trusted system I can get into, this is an idea, product idea, and you can trust me with access to data, why can I not get access to data? We've got the algorithms, we've got the brilliant computer scientists in this country, as we can see then doing innovation in speech recognition, vision recognition, all sorts of wonderful stuff. Why can we not unleash that power on the healthcare data that clearly sits in this country? But we have to get access to that data fast, because then we can actually innovate and bring that to market.
Good question. Thank you. Thank you, Benedict. I think, Tim.
Well, thank you, because you're in the commercial marketplace, and founding a company is fundamentally first, I think a lot of economists have said this, about taking risk. Taking risk means you don't always win, okay? So I just want to start there and say there are lots of things that constitute commercial risk, and thank goodness you're doing it and keep doing it. On our side, I think we do have an obligation, and it's actually not that hard. There are lots of examples of this, of creating data playpens. Actually, it is possible to buy your way into the entire Medicare data set in the United States, de-identified, the whole thing, 360 million people. It's a little bit expensive, but you can buy a seat at the table. Why can't you buy a seat at the table? I mean, talk about democratizing innovation. We should. So it turns out we have plans to create that, buy a seat at the table. We're not all joined up on data. Nor, by the way, is the Medicare data set all joined up. It's a claims data set. But I want to emphasize that is an engine, what you're describing is an engine for innovation, and frankly, it is on us to provide that engine.
Yeah, great answer. Benedict, I can see that you're quite pleased with that. Is David Seymour here tonight from Health Data Research UK? Hi, David, because I think you might also be able to give some good signposts to Benedict, perhaps over a glass of something cold in a moment. But I'd like to bring you in with your question, if you may. So, David's from Health Data Research UK.
I guess we've talked, haven't we, about the sort of the COVID response and how important sort of the convergence of care and research sort of has been, and particularly the alignment between NHS, government, industry and academic researchers. Keen to hear the panel's perspective as what you see the role of research and the research community in transforming healthcare. And I guess in particular, what sort of infrastructure and capabilities do you think are required to sort of make that a reality?
Yeah, I'd like to steer that question, if I may, to Ros. Is that okay? Thank you.
As I said earlier, we have put R&D is one of the big bets that we have made as a country. I think you can see a succession over the course of the next years. You will see a succession that almost being realised, right? So we announced last week 5 healthcare missions in 5 of the biggest problems facing the NHS. For us, the real sort of benefit stroke, the payoff comes when you actually start seeing those that collaboration between the NHS and industry turning into driving better health outcomes than we would have had otherwise. So I suppose for me, it's almost a different question, which is, well, what's getting in the way? And of course, lots of things are getting in the way. One of the things that's getting in the way is clinician workforce time and all the other problems that they have. So then for me, it is less it's clear that we want to do it, and it's clear it can have a really big impact on health outcomes. So then what are the things that are getting in the way that we can change? Those are all things that are on the minds of everybody, I think, on this panel. There are no simple answers to any of them, because if there were, then we would have put a whole bunch of more people into clinical research, and we would be in a much better place than we are. If there were answers, we would then see sort of consistent uptake of R&D across the country, which again is a key challenge. So for me, it's a slightly less optimistic end than I wanted to have, to say it's something that's clearly has to be at the heart of our approach. There are a bunch of challenges, but we are trying to knock them off one by one. But if we don't, I think we will never get sort of to the place that we've all been describing. And the 20 years from now, the people sitting on this panel will be saying, well, they launched their life sciences vision, they had all their optimism, and that's not where we want to be. Like, collectively, there is so much will across the system to make sure that that's not the case.
Thank you. Yes, please, very quick.
Really helpful. I think one area that I actually would like to pick up on, or perhaps again over drinks, is actually the role of funders in this. Because I think we've got a lot of different funders that aren't necessarily fully aligned behind those missions. And so, well, actually, how do we have a whole system driving forward? And that was one of the things that happened during COVID, even though there was still a huge amount of activity happened, but actually clear research strategy and funding across all of the different funders aligned around that.
Just very quickly, hand the mic back to William once Ros has answered.
That is a very timely question. You probably are aware that there is a little organisation called OSCAR, the Office Responsible for Coordinating Health Research, and their chair, Lord Kakar, is in fact going to see the Secretary of State tomorrow to discuss this very topic. So it is one that I'm really focused on, and I think there's no funder who doesn't want to be funding the right things that government priorities. The challenge is how you manage to make the shifts fast enough. We had a burning platform, to go earlier, to refer to our earlier conversation, during COVID, which made it easier to feel as if you could make those shifts. So I guess in part there's a question of how can we create the conditions for that to feel possible now.
Right, I want to finish with our investment climate kind of questions. And forgive me, Ros, I'm going to put you on point for this one as well. How can NHS England attract investment by the not just NHS England, but how can the UK attract investment by the pharma industry and other organisations in research and clinical trials, while the NHS and UK are in a fiscally challenged environment? So that's one, I think, for Ros, in the interest of time. Ros.
So for me, it's a really simple answer, which is it comes down to the conversation, the right conversations happening between NHSE and industry. There is, no shortage of companies wanting to have those conversations, but there's also actually not quite no shortage of creativity within NHSE, but I've been like super surprised and enthusiastic by their desire to have a conversation about how to drive health improvements and investment. So the two things go hand in hand. It requires partnership.
And Bob, can you just make a comment in respect of diversity and how you?
Well, there's an and bit to that. Is then how do Ian and I and all the teams we work with Tim and co to genuinely adopt this innovation there? And there's plenty of examples where we've done that in a patchy way, and we've got to get a better how. We're not great at the how in the NHS. I'm really interested in how we do more of that well. That's
great. Thank you. So, final poll question, which is actually the first one. I've actually not asked our marketing question, but as I'm the marketing director, that's okay. How confident are you that the UK, although my marketing manager will kill me, how confident are you that the UK will achieve its ambition to become a world leader in health innovation? So remember, we asked this at the start. So those that are very confident, show of hands. Oh, same two. Right.
But can we just say thank you to you two? You've been a really encouraging front row, and also...
Yeah, I was a bit bothered about the money that I saw going under the table beforehand, but anyway. Confident. Oh, that's a much better show of hands. Thank you. So panel have done a great job today. Somewhat confident. Not confident. Not confident at all. Benedict's only put up one hand this time, so we've moved. Thank you all to our absolutely fantastic panel tonight. They're going to stay for a few drinks with you all, and there are drinks at the back there. To Tim, to Bob, to Ian, and to Ros, thank you so much for making it a conversation. To you, the audience here, for making it a conversation. This is our last event for 2022, and we're pleased to say that because of the fantastic participation we've had all year, we're back out around the country in 2023, expanding our broadcast to involve half-day seminars with more topics and interaction, and me not being a bossy chair. So we look forward to seeing you in Birmingham, Manchester, Glasgow, and here again in London. If you'd like to watch the video of tonight again, please subscribe to the Chamber UK YouTube channel, where you can watch, like, and continue the conversation online. And more importantly, we thank our studio audience and online audience and say good night to our online audience now, and welcome our studio audience to stay for a drink and some nibbles at the back of the room.